Good afternoon. Welcome to the Heritage Foundation in our Lewis Lehrman Auditorium. We, of course, welcome those who join us on our heritage.org website, those who will be joining us on C-SPAN this morning, and other networks in the future. We would ask everyone here in-house if you'll check that cell phones have been turned off as a courtesy to our guests. And, of course, we will post the program on the Heritage homepage following our presentation for everyone's future reference. Hosting our discussion is Dr. Steve Bucci. He is director of our Douglas and Sarah Allison Center for Foreign and National Security Policy. He has served for 3 decades as an Army Special Forces officer and top Pentagon official, and immediately prior to joining us here at Heritage, he was the lead consultant to IBM on cybersecurity. Please join me in welcoming Steve Bucci. Steve?
All right, I'd like to add my welcome to everyone. This is a big issue, the topic of Ebola. It's a major international and domestic public health quandary. There are lots of opinions flying around, lots of gut feelings, frankly, lots of fear. There's very visceral reactions to this problem. People recognize it as a horrendous disease with a high mortality rate, really scary symptoms, and probably the scariest thing about this time right now is we're like a week away from an election. And that, I'm not saying that totally tongue-in-cheek, that does affect people's opinions on things. But what I'm hoping this morning will do, will inject some reason, some facts, some calm. She works for me too. That was not a setup. We wanted to bring together a panel that could really hopefully give some logic and reason to this whole thing. I mentioned to the panel before we came in, it's probably, this panel has more degrees than any panel I've moderated in my nearly 3 years here at Heritage, and it hopefully will meet the needs of the group here. Before I introduce them, I will say this. I'm going to give each panelist about 10 minutes to speak on various aspects of the issues set here. Then we're going to try and get as much time as possible for Q&A. I really, and I say this every time I moderate, but we don't have time for floor speeches. So when it gets to the Q&A, please ask a question, identify yourself, ask a question succinctly so we can get the answers from the panel that everybody in the audience wants to hear. If you really want to give a speech here at some time, see me afterwards. We'll talk about it and get it arranged, but not this morning. Okay, introducing the panel. We have first Dr. Bob Kadlec. Bob is the managing director of RPK Consulting. He has spent 26 years as a career officer and physician in the U.S. Air Force. He had senior positions in the White House, the Senate, the Department of Defense, and was a special assistant to the President and Senior Director for Biodefense Policy on the Homeland Security Council. He has degrees from the Air Force Academy. He has a doctorate in medicine and a master's in tropical medicine and hygiene from the Uniformed Services University of the Health Sciences and a master's degree in national security studies from Georgetown. Next to him is Charlotte Florence. Charlotte is the policy expert here at Heritage for Africa and the Middle East, dealing with economic freedom, democratic institutions, development, and security cooperation. She was also an expert on international security and foreign policy issues for the Senate Homeland Security and Government Affairs Committee and for then Senator Scott Brown. She has lived and worked in Africa before. And she holds a bachelor's degree from the University of Southern California and a master's from in the War Studies Department at King's College of London. Next to her is Dr. Tevi Troy, who is the president of the American Health Policy Institute. He was the Deputy Secretary of the United States Department of Health and Human Services. His actions there included implementing issues combating bioterrorism and public health emergency preparedness. He was also the acting assistant to the president for domestic policy, during which time he ran the Domestic Policy Council. He is presently writing a book about presidents and disasters and how they responded to them. He has a Bachelor's of Science in Industry and Labor Relations from Cornell and an MA and PhD in American Civilization from the University of Texas at Austin. And then our fourth panelist is Dr. Tara O'Toole, who is a mission manager and senior fellow at InQtel. Dr. O'Toole was the Undersecretary for Science and Technology at the Department of Homeland Security. She served from November 2009 to September 2013. She was, before that, was the CEO and director of the Center for Biosecurity at the University of Pittsburgh Medical Center and a professor of medicine and of public health at the University of Pittsburgh. She also was a major designer and actor in two major bio-related exercises before that, one known as Dark Winter and the other known as Atlantic Storm. She has a medical degree from George Washington University and a master's in public health from Johns Hopkins University. And I will just throw out, while I'm not giving any remarks on the panel, if there are questions about the specifically military aspects of the mission going on in Africa, I'll be happy to try and field those as well, because as a Special Forces officer, I worked in Africa quite a bit, and we did a lot of humanitarian operations in the past. So with that, I will pass it to Dr. Cadlick.
Well, thank you very much, Steve, and for the panelists, thank you for having the opportunity to be here with you today. I think the best way to phrase my comments about the Ebola crisis today is kind of reflect on a great philosopher, someone of contemporary nature by the name of Yogi Berra, this is deja vu all over again. I think one of the things we need to understand is that this issue, Ebola, as immediate crisis it appears today, is not something that has been, first encountered today. I mean, we've gone through a series of exercises and events in the last decade or two that I think have highlighted really the importance of and the necessity for the kind of preparedness that, quite frankly, is not really something we put in the lexicon of national security today. But clearly, I think the events of the Ebola crisis, regardless of the domestic political impact, has really reflected the fact that this is really inalterably going to change a part of Africa and maybe the world on our ability to mitigate and contain the outbreak as it stands and it's emerging. So let me be a little concrete on that. Back in 1992, and I dare say many people may not recall this, the Institute of Medicine drafted a study that two very notable virologists, I should say a virologist and a bacteriologist, penned. One was named by the name of Joshua Lederberg, who's a Nobel laureate for his work in bacterial genetics. The other one was Robert Shoup, who's a virologist distinguished from Yale University. What they kind of outlined in that very little monograph, which you can still get today online or in a library, was really the impact of emerging diseases around the world. It recognizes that the change of human behavior, the change of the environment, the change of every aspect of our life, including the media revolution we have, was going to impact on our ability and our perception of not only emerging diseases, but what impact it would have on our society. It's worthy of note, even then, they identified the need for some kind of deliberative manner to manage these kinds of outbreaks, because in all likelihood they were going to happen with greater certainty in the future. And again, the certainty they had was man's interface with the zoonotic reservoirs for a lot of exotic diseases. So they identified the role of urbanization. And as we see here, that was a critical link in the current Ebola outbreak as it relates to the likelihood that this would be something more than a flash in the pan that it has been before. Historically, Ebola has occurred in remote villages where people were limited by their ability to walk any distance or have access to healthcare capabilities. So many of these people who were affected basically perished in their villages, and the results of those outcomes and the consequences of those outcomes were contained then. If you recall, back in the spring of this past year, Ebola found its root in an urban environment. And that really changed the complexity of the outbreak and the role of transmission that's in that setting. So in areas, and certainly where they had healthcare facilities, even primitive by our standards, became a focal point of propagating the disease, as well as cultural practices and other things that you've read in the newspaper. But it just highlights the fact that in some ways the world has changed, we have changed, and we really need to keep up with that. One of the areas I was asked as a part of this panel to focus in on was domestic preparedness. So let me just spend a moment to talk about that in the next 5 minutes or so. My background, it wasn't really detailed by Steve, but Steve and I have I guess a familiar background in the sense we both spent time in special operations. I did so as a medical officer. And I'll give you a quick anecdote of what I learned in my 20-some-odd years of being a medical officer supporting special operations. I entered it at the, if you will, the nadir of American special operations, right after the tragic events of Desert One, when we failed miserably in terms of rescuing hostages out of Tehran. And with that, it was recognized by the Holloway Commission that there were certain essential elements about the future of American special operations to meet contingencies that we couldn't define today, but we know that we would encounter tomorrow. 4 very simple ideas. One was recruiting, one was training, one was equipping, and one was exercising. And with that, that became really the hallmark of what, again, American Special Operations Forces over 2 decades focused on. Recruiting the best people, training them, equipping them with the state-of-the-art capabilities that we had, and exercising them under realistic conditions. And people like General Wayne A. Downing, people like Stanley McChrystal, all basically embraced that concept. And with it, if you can look at it, the denouement of this experience was the events subject in Abbottabad, where we basically ended the life of Osama bin Laden. It wasn't something that happened in one day, 1 week, 1 year, but literally decades. And so I'm arguing today to you that there's no such thing as just-in-time preparedness. That the commitment we make around healthcare and public health preparedness for Ebola, as we see it today, and future outbreaks, maybe pandemic influenza, maybe other things that are just as bad or maybe worse that could occur, and these are natural events, and we're not even talking about terrorism here, are things that really you have to put our mind to it. So let me give you some basic concepts about what we're committing to around domestic preparedness today. Our healthcare industry is about $2.8 trillion a year activity. The federal government invests about $250 million in hospital preparedness. That's 1%. We spend more money on potato chips in this country than we do on healthcare preparedness. So that's one thing to kind of keep in mind. We spend between $8 and $9 billion a year on national missile defense. And overall, if you look at our entire expenditure on medical preparedness, that includes the drugs and vaccines that we need, as well as healthcare preparedness, is somewhere between about roughly $7 billion. So we're paying more to protect ourselves against the existential threat that's represented by a single nuclear-tipped missile than we're spending on the likelihood of an event, maybe like a pandemic influenza, like the Ebola crisis, and if you will, even potentially some kind of deliberate act that could happen in the future by a terrorism or a state actor. So in some ways, we have not yet quite conceived of how we need to think of this capability. One thing you need to understand is that there's no political divide over this. During my tenure in the Senate, it was a circumstance that where two opposites attracted each other and were able to do extraordinary things. One was Senator Richard Burr from North Carolina. You could call him a conservative moderate. And the other one was Ted Kennedy. You can call a liberal from Massachusetts. But they worked famously together, and their pairing wasn't by accident, because in fact it was created by a relationship that occurred between Kennedy and former Senator Bill Frist early during the Clinton administration, when the Clinton administration realized that these issues would figure prominently in the future, subject of not only the world we lived in, globalization, human behavior, but the likelihood that these diseases would be more likely to become significant in a very highly connected world. And so with that, it was the idea that they had, Senator Kennedy and Burr, that somehow we had to kind of have the same institutions that in some ways we have in the national security realm, in the Department of Defense. And I'll use a significant example, which is Goldwater-Nichols Act of 1986, which reorganized the Department of Defense to give us what we have today, a highly capable joint fighting force, was the model that was used to create the Pandemic All-Hazard Preparedness Act. You may kind of wonder about that, but it may reflect in some ways my military background, but it really reflected, if you will, the need for the nation, and that was a coherent means to effectively work across the interagency, the federal government, the Department of Veterans Affairs, Health and Human Services, Department of Defense, who have major medical assets, as well as the state and local activities that really are the frontline fighters in this. But the point was to create someone in charge, which was the Assistant Secretary for Preparedness and Response. The other thing was to create an entity or an activity that would really give the chance to develop medical countermeasures that we would need to fight an outbreak like Ebola with the vaccines and therapeutics and the diagnostics that were necessary. And in that case, it was a circumstance where it was recognized that there was no commercial interest in a vaccine like this until something happened, and that was way too late, given that it takes about 10 years on average to develop a medical therapeutic or a vaccine, and cost about $1 billion. So you can imagine the reluctance of the pharmaceutical industry to basically embrace that cost without any guarantee of a market. And so there were things that the federal government did that were extraordinarily important in the times right after 9/11. One was basically creating BioShield, which was a guaranteed market for countermeasures, about the amount of $5.6 billion over 10 years. The second was the creation of the ASPR, which was really about how do we put somebody in charge of the overall federal effort to these kinds of events. And the third thing was really how do we make the medical countermeasures we need. Part of that was investing into NIAID, Tony Fauci, who's if you will, the poster child of that organization, an articulate spokesperson during this Ebola crisis, and a true scientific expert in these areas. But also the idea of how do we build not only what they take from research and development, but how do we make it into a product that we can stockpile and use. And that was the function of the Biomedical Advanced Research Development Agency, also known as BARDA. I would argue that over the period of time that these things have been developed, in some ways we've kind of lost our eye on the ball. That between crises we seem to take for granted, if you will, that things are being adequately covered or funded, but in reality those things have suffered significantly from that. But it is a circumstance, I think, that we need to look forward to after this Ebola crisis will end, and it will end, that we need to be prepared for the next crisis in a way that may be different than this one. We're fortunate that this is not an airborne transmitted organism. Certainly it can evolve over time into something more virulent, but I don't think that's the estimate of the experts today, and I think that's very reassuring. The second thing is that as far as Ebola goes today, is that it's limited in a geographic area that, quite frankly, makes it manageable if we can get ahead of the virus. Michael Osterholm, a noted epidemiologist from University of Minnesota, has talked about the virus time, and that we're behind the virus time. And so until we can catch up and use the resources we have to effectively limit the spread of this disease on the continent, in the world, I think we're better off. And certainly from the United States perspective, we can demonstrate, and we have so far, that we can manage these sporadic cases very well. Certainly if there was a greater influx, it would be more challenging. But right now we have a bit of time to effectively train healthcare workers to recognize and effectively isolate and quarantine people who may have been exposed to this disease and who may have the disease. And that's functionally something we need to do. And we do need to buy time so that for the vaccines and therapeutics that we have in the pipeline, if you will, that are being rushed, if you will, to being used through clinical trials that will be done here in the United States and Africa, we can buy time and hopefully save many thousands of lives by fielding them appropriately. With that, I think I've hit my time, and Steve, I'll turn it back to you.
Thanks, Bob. Charlotte?
Great, thanks Steve, and for also putting this panel together. Good afternoon, everyone. So today I'd like to highlight some of the governance and geopolitical considerations in West Africa to combat Ebola. Ultimately, containing the outbreak in West Africa will make the United States and the world safer. As long as the outbreak continues to grow in West Africa, everyone is at more risk. Of the 3 countries facing widespread Ebola transmission, Guinea, Liberia, Sierra Leone, the Ebola crisis is just layered upon already quite volatile and challenging developmental situations. Liberia and Sierra Leone endured years of civil war, and there is still a United Nations peacekeeping operation in Liberia. Guinea recently experienced a coup in 2008. While Sierra Leone is ranked the highest among the 3 countries in the Mo Ibrahim Index of African Governance, all 3 countries' scores are below the continent's average. Guinea is ranked a dismal 42 of the 52 countries measured, with Liberia not far behind. And looking at the UN Human Development Index that measures aspects of countries based on life expectancy, child mortality rates, education, and formal employment, among others, Liberia is ranked 175 of the 187 countries measured, Guinea 179, and Sierra Leone 183. Years of bad governance, ongoing conflict, poor fiscal management have plagued these countries. Despite relatively high growth rates and an increase in FDI in the post-conflict era in Liberia and Sierra Leone, significant governance challenges remain. This, coupled with urbanization and an increase in travel links from rural villages to cities and across borders, created an environment much different than previous Ebola outbreaks that had been isolated to relatively remote areas in Central Africa. Ebola spread across the region in a perfect storm. Local governments did not act quickly, and the international community did not heed these early alarms. Or even as the case with Liberia this past August, the Liberian government took desperate and an unhelpful measure when they quarantined West Point, the largest slum neighborhood in Monrovia, the capital of Liberia. The slum quarantine created more internal problems, spread the disease further, and eroded what little trust was left in the national government. More than 50,000 people live in packed shacks in West Point. It is the perfect environment for the disease to radically spread. There is also limited education about the disease that meant public health officials were unable to get ahead of some of the cultural and behavioral challenges that only speed up transmission rates with Ebola, particularly around the burial of victims. Like many places in the world, families grieving the loss of loved ones wanted to ensure that they were given proper burials, which at times included improperly removing the body from black body bags into traditional white burial shrouds, or washing the bodies themselves. Bodies are extremely contagious after the person is dead. The U.S., in partnership with local governments and NGOs, along with education campaigns in these countries, are working to get ahead of some of these behavioral and cultural challenges. One easier fix has been just to blanket use white body bags that the caretakers are using. And there have been some small improvements on the ground. Even the head of the Liberian government's Ebola response has applauded West Point as one of the few Monrovia neighborhoods where residents have taken charge of the containment effort. Some may argue that's because the government was not present for quite some time. Still, there are not enough ambulances or beds in hospitals to accommodate the increasing number of Ebola victims. And organizations such as Doctors Without Borders are resorting to distributing home care kits because they don't have enough beds or vehicles to get victims to emergency treatment units. Of course, this is better than nothing, but still insufficient to medically treat infected individuals and ensure proper isolation. Things are just not moving fast enough to get ahead of the infection ratio. Because of infrastructure challenges on the ground and the start of the rainy season, the USAID-led humanitarian operation has been slow to get off the ground. In addition to the heavy toll Ebola has taken on the lives of individuals in the Ebola-affected countries, we're now starting to see the real second and third order ramifications of the outbreak. Upwards of 3,700 children have been orphaned in this crisis. Most health facilities and community health workers have been redirected to the Ebola effort, meaning those with common diseases in the region, such as malaria, TB, HIV, and even pregnant women, have fewer places to turn to for care. It's estimated that nearly 800,000 women will give birth over the next year in all 3 countries combined. In Sierra Leone, 57,000 people are living with HIV. Nearly 3,000 died last year from AIDS. Schools have also been closed for months. There's a real possibility of food shortages affecting these countries. Markets have been closed. Farmers aren't farming. People are unable to work. As the World Bank has highlighted, beyond the immediate economic cost to contain the epidemic, There are serious indirect and long-term economic consequences, including foregone output, higher fiscal deficits, rising prices, lower real household incomes, and worsening poverty. Growth estimates for Guinea have been halved from 4.5% to 2.4%. The country has already experienced an exodus of farm workers, critical to their key export products, such as coca and palm oil. For Sierra Leone, a country that is often cited as one of the fastest growing economies in Africa, with an annual growth rate of over 11%, their projected economic growth has dropped to 8% in 2014 and likely to be no growth in 2015. The country has also experienced a substantial slowdown in critical mining operations. In the hardest hit country of all, Liberia, the World Bank revised its 2014 growth projection from 5.9 to 2.5%, and will likely experience negative growth in 2015. Accelerating the economic downturn, Liberia's two largest companies have also suspended operations as a result of the outbreak. Again, to reiterate, if we're going to protect the United States against Ebola, ultimately addressing the problem, not the symptom, will be critical to containing Ebola in the long term. Non-Ebola affected African governments also need to commit to this effort, because just as the U.S. faces this challenge, the heart of the Ebola outbreak is in their region and in their neighbors' yards. I do want to highlight that Uganda, along with the DRC, countries that have faced Ebola outbreaks in the past have continue to help the Ebola-affected countries, providing healthcare workers and training. Enhanced cooperation will be necessary among international partners, Ebola-affected countries, regional and community leaders, and the private sector to address the crisis and lasting economic and social consequences of this outbreak. So the bottom line is the U.S. will only be safe once the outbreak is contained in West Africa.
Thanks, Cheryl. Kevin?
Thanks very much for putting this panel together and for moderating. I agree with just about everything that my co-panelists have said thus far. The only exception I would make is a minor one, and in contrast to what Steve said, I do not believe that the fact that we're having an election next week is the scariest thing about Ebola. Now, Steve, I hope you take that comment in the humorous vein in which it was offered, because I have a rule in life which is never to anger members of the special forces. So I hope you do not take offense. As Steve mentioned, I am writing a book about presidents and disasters, and I'd like to look at this situation in the context of presidential leadership and the need for presidential leadership to address these kinds of situations. And I'd like to take a little step back into history to the 1918 Great Influenza, or Spanish influenza, which I think is a misleading term for it, but it is nevertheless what it is known by. In any event, that influenza took place during the time of World War I, and as Charlotte was saying, there's certainly a problem of correlation between difficult situations, whether it's economic or war zones, and the spread of diseases, and it is almost certain that the 1918 flu was exacerbated by the disaster of World War I, by troop movements, by the establishment of refugees, of instability, and in many cases by U.S. policy. There were 675,000 Americans died in the 1918 flu. And as many as 50 million died worldwide, but in the U.S. it was 675,000, which is a staggering number. If you think about the number of U.S. soldiers who died in World War I was about 116,000. Now there is overlap between those 675,000 and the 116,000. So because some of the 116,000 died of flu, but in any event, the number of people who died from flu, the number of Americans who died from flu, is a much greater number in that situation. And in the process of working on my book on presidents and disasters, I looked into what President Wilson did about this really disastrous situation, the worst disease outbreak in U.S. history. And I'm really shocked and somewhat mortified to say what President Wilson did was basically nothing, as we had this disastrous situation and hundreds of thousands of Americans dying. There was one point at which his own personal doctor, who is a Navy physician, said to him that we've got this problem and it is being spread in part by U.S. troop transports, and the U.S. troop transports not only spreading the disease among other Americans who were in these narrow confined conditions as they're going across the sea to fight in the war, but also it is spreading the disease around the world as American troops are deployed in different places. And President Wilson raised this issue in the White House with the person who was the equivalent of the Army Chief of Staff at the time, and this the Army General said that we absolutely could not change troop transports in any way. We could not change our policy, that we needed to send as many troops over in order to win the war, and that there was to be no change in policy at all. And to this assault from the general, President Wilson weakly assented and raised no other point about it. Now, this is particularly interesting, and you can see that perhaps the general had a point, and I also try not to, in addition to not angering Special Forces members, I try not to contradict generals too often, but the fact of the matter, when they had this conversation, it was 1 month from when hostilities in Europe were about to end. So it is not as if this was a key point of the war. This is pretty late in the process. Another aspect of the Wilson administration's approach to this was not necessarily directly related to the disease, but it had negative repercussions, which was there was a very strong propaganda effort by the U.S. during that war in order to not only promote happy talk at home, but also to really suppress dissent. And it was actually a kind of frightening time in the U.S. There was a guy named George Creel who was the head of the Office of Public Information and had a much more directive approach to it than you would have someone, let's say, USIA today. And in that effort, they really pretty much suppressed talk about the flu. They did not try and scare people about the flu, and they made everything, and President Wilson was pretty explicit about this, was everything was about winning the war. And there were more things that the U.S. could have done. In fact, there's a sharp contrast between the cities of St. Louis and Philadelphia, both of which were about the same size at the time. And St. Louis instituted social distancing. It said you shouldn't get together for big parties, and they tried to suggest people not to get together at movie theaters and the like. And Philadelphia put together no such suggestions. And the death rate in St. Louis was about 5 times less that of Philadelphia. Now, the truth of the matter is, we didn't really understand that much about the disease at the time or disease spread, and we know a lot more today. But the fact of the matter remains is that you need presidential and good government leadership in order to deal with these situations. And I take to heart Dr. Kadlec's comments about the need for bipartisan cooperation. In the mid-1990s, both Speaker Gingrich and President Clinton, who, as everybody recalls, were in the midst of some pretty nasty partisan fights between themselves, both of them read the book The Hot Zone by Richard Preston, which deals with form of weaponized Ebola, and agreed that there were things that the U.S. government should do to be better prepared, and Dr. Bob talked a little bit about that. In 2004, President Bush read a book by John Barry called The Great Influenza about the situation I talked about with the Spanish flu, and he was very moved by that book, and in addition by the fact that the U.S. government did precious little about that situation, and pushed the U.S. government to have a plan in place for flu. It's something that I worked on both from the planning stages at the White House, but also the implementation stages when I was over at HHS. And it included a number of components. Dr. Bob talked about some of them, including the development of countermeasures and the storage of countermeasures, and the answering of key questions about how to deploy, how to distribute resources, who's in charge in various situations, and included a number of types of scenario planning and exercises. And what we found is that every time you had these kinds of exercises, and I'm sure Tara Toole can talk a little bit about exercises and how useful they are, you raise questions that you didn't have answers to. You find out that there are holes in your system and things that need to be addressed better, and things that you need to think about for the next time. So transitioning out a moment for Ebola, I think that I wouldn't call it an exercise because obviously the devastation is Florence talked about, was somewhat is devastating in Africa and extremely problematic, and there's certainly a lot of panic, and there's been unfortunately at least one death in the U.S., and there potentially could be more. But this whole situation has raised questions that we need to think about and to answer, and has highlighted certain holes or flaws in our system. And I will put them really in four categories. I'll call them the 4 Ds. There's detection, development, deployment, and directives. In terms of detection, I think that the U.S. government was a little slow to pick up on the extent of the problem of Ebola. Now, it's not just the U.S. government. I think the World Health Organization has been almost criminally asleep on the job in this, and should have been warning about this sooner. And it's not just Ebola. In 2009, when we had the H1N1, the Mexican government was very slow to pick up on the problem of what was going on in Mexico with the H1N1. And PAHO, the Pan-American Health Organization, both of them were about 3 weeks behind what certain private sector companies were able to detect was an emerging problem. And the truth of the matter is, we have much better technologies for detecting problematic disease outbreaks today than we have had in the past. And even something as simple as Google searches can give you information about the development of symptoms in a certain area. Now, obviously, we need to be more refined and more technologically savvy than that, but it's just an indication of the kinds of tools that we have now that we do not have in the past. So I think we need to be faster about detection and picking up on these issues. Second, in terms of development, and Dr. Kadlec talked about this a little bit, we obviously have been way behind in terms of developing countermeasures for Ebola. And when I say countermeasures, I mean some kind of vaccine or some kind of cure. I know it's very hard to cure viruses, but there are antivirals that are dedicated to certain conditions, and I think we need to accelerate efforts on that front, and we have been accelerating efforts on that front, and especially on the vaccine front. You know, NIH in 2000 announced a promising trial for dealing with Ebola vaccines for Ebola in monkeys. And now 2014, and there's an Ebola crisis raging, and that vaccine, and no vaccine has yet to reach a commercially approved, available situation. So we need to improve our development of countermeasures to deal with these kinds of problems. In terms of deployment, there's all kinds of questions about the use of the U.S. military, and I agree with President Obama's decision to send troops there, but there are questions about rules of engagement, and there have been a lot of questions about what exactly they'll be doing. I think they're doing the right things in terms of building capacity and in public health facilities in West Africa, but it seems like some of this stuff is being figured out on the fly. Also, there was a report by the Inspector General at the Department of Homeland Security that said that the Department of Homeland Security seems woefully ignorant of what all the countermeasures that it has and how it would distribute them in times of crisis. So we don't necessarily have all the answers in terms of what we have and what we could potentially send around if needed. And then in terms of directives, every time we see another Ebola situation in the U.S., it raises questions about travel bans. It raises questions about whether people should self-quarantine or have imposed quarantine. What are the CDC protocols? And these things are being adjusted. And I think for the most part, CDC has done a good job in recognizing, as Dr. Kadlec was talking about, the differences between dealing with Ebola in a rural first world health situation and in a modern urban healthcare setting. There's different dangers and there's different approaches, and we need to be cognizant of that in developing our protocols. But I think as we learn from every exercise, it seems like there are additional questions that need to be answered. So in sum, I would say that we are much better off today than we were, let's say, even 10, 12 years ago in terms of dealing with some kind of dangerous viral outbreak. But there are still many questions that need to be answered, and we still have more work to do. Thank you.
And Dara, you get that cleanup.
Okay. Well, thank you for having me. Many aspects of this Ebola outbreak would have been familiar to people fighting in the Peloponnesian War, which was interrupted in important ways by some kind of epidemic we still can't identify. Maybe it was plague, maybe it was smallpox. But epidemics of infectious disease are something that have been riven as major events through human history. Tevye mentioned the 1918 flu. We can also think of the Black Plague, which killed a quarter of the Earth's population at the time, a circumstance which some historians attribute to the beginning or think was very instrumental in the beginning of capitalism. But epidemics are always with us. We have had an unusual 100 years in the developing world in which epidemics have been much less present and much less terrifying than they were in previous history, in part because of better sanitation and nutrition in the developed world, in part because we have antibiotics and better science. In 1918, we didn't know what a virus was. We literally didn't know that viruses existed. So this explosion in medical and biological knowledge that we've had over the last century, and in particular, I would argue, in the last 50 years, has been a game changer. But we're now in a period when we can expect to have a lot more epidemics that challenge us. And I will leave bioterrorism aside, which Bob and I and Tevye can go on for hours about, but that will be another
Really, hours.
lecture. At least off the top of our heads. We're adding 70 million people to the planet every year. We're living in megacities where most people have poor sanitation and nutrition and are living right next to their animals. 2/3 of the emergent diseases that we've discovered in the last several decades have been zoonoses, as Bob said, that infect both animals and humans and jump from one to the other, as AIDS did from apes, as Ebola has done, presumably from bats and or monkeys and chimps. We live in a world in which you can fly around the planet in 24 hours as opposed to the 6 weeks it took a steamship to cross the Atlantic in 1918. And we are very, very interdependent in terms of supply chains and our economies and the way we live our lives. As you saw, Mr. Duncan, the gentleman who got sick in Africa and died in Texas, came over to be with his family. That didn't happen a whole lot, even a decade ago, let alone 2 decades ago. So we're going to have a lot more epidemics, and we have a lot fewer effective antibiotics because of our misuse of those miracle cures. And we have been trying, in the U.S. government at least, over the past couple of decades, to get better at our response to these events. Now, the things that are similar in all epidemics, no matter what the bug is or where they occur, is first of all, it's very hard, as Tevye said, to see the beginning. They start slowly. These are not lights and sirens events. They're not like explosions. By the time you see them, usually, even in the U.S., they're bigger than you'd like them to be, because what you want to do is see them soon and quench them when they're little. We've tried all kinds of surveillance approaches for infectious disease, and none have worked very well for reasons we can discuss. We got to get better at that. One component of that is really good rapid diagnostics, not our current situation where we can do PCR or ELISA tests and we get the answer back in a modern hospital in 48 hours, in days in Africa. We need something that works more like a Band-Aid that turns blue, or a pregnancy test that individuals can apply and figure out if they need to isolate themselves or stop worrying. Another aspect of epidemics is that they always engender a particular kind of fear. It is a visceral fear. We can argue about why that is. It's one of the reasons that so many novels are about plagues. It's pretty freaky to think you might end up bleeding from your eyeballs in the case of Ebola. But also, disease is something that comes into your home. So people immediately worry about their children in particular and their family. And everybody feels vulnerable in a disease. And after 9/11, everybody in this area of the country was very focused on that event and feeling very shaky about it. You went out to the West Coast, it was a very different situation. They felt very removed from being targets. All right? Not so with disease. Everybody feels vulnerable. So fear drives a lot of the reactions amongst politicians as well as normal people all the time. They're not over fast. This is not going to be over in a month or a year, and I think that's perhaps something that the governors who imposed quarantine in the Northeast overlooked. This isn't going to go away in 60 days. They're looking at having to quarantine travelers for probably a year or two. And let me tell you, there's going to be cases coming out of the UK. Are we going to forbid travel from London? This is going to get, this is going to go on for a while, even if we're very, very successful in containing it. Epidemics always cause social disruption and exacerbate the seams in a society. You're always looking for someone to blame. When we had smallpox outbreaks under Teddy Roosevelt's presidency, the immigrants were blamed. That's actually a fairly common group to blame in any epidemic situation. But people have a hard time understanding the unpredictability of disease and want some surety around predicting why they might be safe or how they might be kept safe or who they could lock up to make them safe. So all of these things happen in every epidemic, and we're seeing them now. Part of what we have to do is understand these phenomena and guard against letting them rule our better judgment. So for a variety of reasons, as I said, we're going to be more vulnerable to epidemics, and we've got to get better at managing them. For a variety of reasons, we're much better able to manage them. Bob talked about all of the different programs that were put in place starting in the late 90s. I would be less polite than Tebby and Bob were. I think they've mostly failed, particularly those aimed at generating countermeasures. We've learned a lot from these programs. They have not been useless. We've had our usual American predilection to fund heavily when the crisis occurs, and then the money dribbles away and gets moved to other things. The money for bioterrorism, about a third of it got moved to flu, for example. Not necessarily a bad thing, but it never came back. And particularly when you're doing R&D, which is a lot of what the countermeasure efforts were, this lumpy, bumpy budget pattern is very cost ineffective because you never figure out if what you invested in the front end was working or not. We are at an amazing moment in the history of science and technology. Biology is entering a revolutionary phase, building on the achievements of the computer advances of the 20th century. And we are beginning to understand, in a serious way, the parts and circuits of living organisms, how living organisms organize, build, and manage themselves. We have a capacity now to really take on the task of being able to recognize disease as it comes, as it first appears, and also to be able to generate the diagnostics, the drugs, and the vaccines we need when we need them, rationally design vaccines, manufacture them at scale, and distribute them where they need to be. We should take that on as a national security priority. But it has to be a very serious strategic undertaking. I can talk about why I think the science and the technology is there. I think the fact that we don't have that already in infectious disease is a clear market failure. Infectious diseases is not something pharma is investing in. Bob knows this deeply and well. They can make a lot more money, magnitudes of order more money, investing in pills that you're going to take every day for the rest of your life, like Lipitor. Infectious diseases, you take that antibiotic for 2 weeks and you're over. just don't make a lot of money off of it. So we've had a remarkable diminishment in the last decade in the pharma investment in anti-infectives, and we've got to do something about that. And we can. I was going to say something about the response in American hospitals. Let me just say 2 words. I think the rest of the medical system learned a lot from Texas. I was very surprised that Texas was unable to manage containment of an infectious disease. This is a big, sophisticated hospital that we're talking about. I think what we've learned is that we've probably been making a lot of mistakes in disease containment all along across the United States, but it was more forgiving with infectious diseases like tuberculosis and HIV. You make a mistake with Ebola, and the healthcare workers who are around these very sick patients with high viral loads are going to get sick. I know Hopkins has now trained about 500 people in this enhanced personal protective gear and procedures that we're now using, and I think other major hospitals are doing the same. So we ought to be able to protect our healthcare workers. That is obviously an imperative both here and in Africa. And I think we will start doing that. I think one of the questions ahead of us is, are we really going to be able to do this in a handful of hospitals, the designated receiver sites, or do we need more hospitals to be able to handle this? If we don't, as Charlotte said, if we do not contain this in Africa, then Ebola will become a fact of life. And every time you get a fever, you're going to wonder what you got in days ahead. So the primary thing we've got to do is we've got to contain this in Africa and understand what's at stake and how much of the burden the United States is going to have to bear to remove this threat from the planet.
So, thank you. All right, I'm going to moderate from up here so I can see everybody better. I have a couple of questions, but I'll let you guys go first because I think there's probably a few out there. We have microphones, so when I call on you, just hold up your hand. We'll get the mic to you, identify yourself, and ask your question within 2 sentences. I want to hear that question mark at the end. Yes, sir.
Hi, my name's Dave Price, retired reporter and educator. One of the questions I have for the panelists, how do you think the media has helped or hurt this? And I have my own feelings on it, certainly. And as you've all said, we can't go back in that. The other is, it's not a question, but I just want to thank the panel. In a time of fear, to hear just stable facts is what we need more of. So maybe this could replace Modern Family or something this week somewhere on TV. Maybe we could give up one, or Honey Boo Boo's been canceled. Maybe it could go into that slot.
We got a slot, yeah. Anybody want to take that? The scorecard on the press, how'd they do?
I'll take first crack at it. I think the media serve an important role in highlighting situations that U.S. government officials or government officials elsewhere would not necessarily be paying attention to. I mean, it's a kind of barometer of what's resonating out there, and I think they've got a good feel for what's resonating. I don't think that, as a matter of policy, U.S. government should follow the media, but they should be ahead of it. But unfortunately, that's not always the case. Now, is there some Ebola panic that is being stoked by the media? Sure, absolutely. And I think some of the coverage about domestic outbreaks has been overly hysterical. But at the same time, it has highlighted the fact that CDC's initial response was inadequate, the White House's initial response was inadequate, and that we need to do better. I think there's a very difficult messaging challenge that public health officials face in this situation. Now, in Public Health Communications 101, what you want to do is you want to avoid panic, right? Because that way you send the worried well to the hospitals and people start storing stuff in their home and hoarding, and you don't want panic. But at the same time, you've got to be absolutely upfront and honest about what the challenges are. And I think there was some happy talk from both the White House and CDC in the initial days that was problematic. Now, in Ebola, I think it's particularly, so that's always a difficult kind of narrow bridge to walk across. But in Ebola, I think it's particularly difficult, and I'll stop with this, because you have the situation that Charlotte was talking about, which is it's absolutely devastating in Africa, and we need to address the problem in Africa. But at the same time, the dangers of a widespread outbreak in the U.S., I think, remain relatively low. That doesn't mean there won't be outbreaks in the U.S., and I expect to see more cases in the U.S., but I think we have the capacity, if we do the right things, and we didn't necessarily do the right things in Texas, as Tara was saying, if we do the right things, we have the capacity to control the spread of Ebola in the U.S. So I think that it's tough from a messaging standpoint, and then the reporter of media hysteria exacerbates the difficulties of the challenge.
Can I add
Yeah,
to that?
yeah.
The other problem is we learn as we go. So the story changes, and the media present that as they really don't know what they're doing. I was surprised that the hospital in Texas didn't do the right thing. And I think that was because we didn't know enough about how to protect healthcare workers against Ebola, in part. Now we're learning that, we're changing those regulations, just to take one little point. That's seen as or presented by some media as the CDC doesn't know what it's doing. And we have to recognize, especially now, when we have much more powerful means of learning as we go, we're going to amend our original views as we learn more, and people have to expect that. I also think some of the best pieces have been in the media, particularly the written media. I think Gerson's article on Friday was excellent. You know, they're tapping into this emotional strain that people find addictive, and it's, you know, not always helpful.
And may I just add quickly that there's both in that the nerve that is struck, I think, is representative from books like The Hot Zone and movies that are sometimes really good and sometimes really bad, that have kind of grabbed people's popular perception, and then that becomes the frame of reference they act upon. So in some ways, it doesn't take much for the media to say to really kind of stimulate that fear in public's mind.
Okay, next question. About right there.
Hi, Rick Barton. I'm a health policy analyst with the Charles Koch Institute. So we're seeing FDA regulations as sort of a barrier to access for some of these new tests and new drugs. Do you think there's any kind of room for reform of those practices, the clinical trials and that kind of stuff, in order to get better access to these in a timely fashion?
Sure, Tara.
I think FDA is doing the right thing. I think the real question is, why the heck do we not have an Ebola vaccine by now? Okay, why didn't that get through these trials before now? And we ought to go back and really look at BARDA, for example, and NIH, both of them are working very hard now, and figure out why it was that we had more than half a dozen Ebola therapeutics and vaccine in the pipeline. We didn't get any of them through by now. Bob personally worked very hard on those programs when they were originally conceived and set up. And they don't resemble those original ideas in their current incarnation. I'm with FDA on this one. I had a colleague, a former colleague, who was taking care of patients in Africa who got a needle stick. Didn't develop Ebola symptoms, but as you can imagine, everybody was very worried about him. And he took one of the new therapeutics and got really, really ill. And you see that a lot in anti-infectives, that, you know, you're trying to tweak the immune system. You're trying to trick the immune system into mustering its defenses against this bug. In the case of Ebola, which, you know, its whole modus operandi is to turn off the immune system and kind of sneak around into all the organs, and the immune system doesn't know it's there until it's really multiplied beyond control. And you turn the immune system on in the wrong way, and you can kill people. So we have to do safety trials. It is crazy to think about giving out, I think, vaccine or therapeutics, particularly therapeutics, without safety trials. We do have to figure out how to do them very efficiently and effectively, about which there's much brouhaha right now at the WHO and elsewhere. But you do not want to just go giving people stuff that's untested in this situation. It could really backfire and cost you the confidence of the public, without which you cannot contain this disease. That's already problematic, as Charlotte said.
So let me build on that a little bit. I certainly agree with Tara that you can't just say it's FDA's fault that we don't have these therapeutics out there. That's certainly the case. The question is, and I certainly think that you can't go forward without safety trials. You do need safety trials. The question is, does FDA change its practices to some degree in recognizing what is a mortal threat to people, and that this disease has very high mortality rates? And you have seen what I call the pendulum at FDA shift sometimes when it comes to facing deadly diseases. So, for example, in the late 80s, early 90s, when you had the HIV/AIDS situation, there were a lot of protesters yelling at FDA and doing some tactics that I don't agree with, like throwing blood on FDA headquarters. But they were saying that FDA needs to loosen up some of the rules on trials in order to allow people who are facing a death sentence to try therapeutics that they might ordinarily not try if they were not facing a life or death situation. And so the pendulum does shift, and you saw the pendulum shift a little bit in that period, and you actually saw in the mid-90s the highest number of new approvals at FDA, and I think those are not unrelated. So this might lead to some of those kinds of shifts within FDA about how to approach these things.
Just to get to your point, though, and there are two principal mechanisms that are used today, compassionate use and also emergency use authorization, which quite frankly allows FDA to make a judgment subject to the data that's available at the time, subject to the use of a particular drug or therapeutic. But I go back to what Tara said originally, which is the first principle of medicine is do no harm. And I think in light of these materials, particularly now, the countermeasure we're talking about now, they're very early in their clinical phase testing, and Tara has raised the right question, which is, well, why is it taking so long if in 2000 we've had an Ebola vaccine candidate? But the answer is they're still very early in clinical evaluation, so the likelihood is they may fail because they're not effective, fail because they can actually cause harm versus actually be therapeutic.
Okay, yes, right there.
Hi, Molly Anders with DevX. And I had a question, this is sort of related to the last one, and sort of about R&D. And Ms. O'Toole, you said that there needs to somehow take place a reform in how R&D is conducted. And again, this is related. Are you seeing any of that now? Are you seeing any of those reforms take place? And what specifically can you see happening on the ground that would have helped?
I'm not sure I understand the question. R&D related to Ebola? Oh, I think there's a lot of people trying to understand the science of Ebola. If you go into any of the major journals, Nature, Science, the New England Journal has been all Ebola all the time for the past several weeks. You'll see them trying, that the experts are trying to gather what's known, okay, and solidify their understanding of what the remaining questions are and how to approach them. Hence the science argument going on at WHO in Geneva and elsewhere about how do we proceed with vaccine trials, for example. The research community will rise to the occasion, but it will do so as it does research, which is individual principal investigator by principal investigator. And what I would argue for is a concerted national effort with very purpose-driven science to figure out how do we rapidly, rationally design a vaccine in the face of emergent threat and then manufacture it at scale. And I think we can do that. I think there's different avenues we can explore. Some of this is actually a big data exercise. Some of this is a manufacturing exercise. But I think I would organize it very differently than basic R&D is usually organized. And I would argue it's time, not just because of Ebola and not just because of epidemic threats, but because of economic competitiveness. It's time for America to have a strategic approach to the biological sciences, to the life sciences we've never had before. We've done it with the physical sciences because we see its importance to national defense. national defense is going to start to depend upon biology in a big way, whether you're talking, well, I'll leave it at that.
But if I could offer one additional thing, there is an effort undergoing or ongoing in the House Energy and Commerce Committee, which has, if you will, domain of health issues for the House. And that is the 21st Century Cures Initiative, which is not directed about Ebola, but may afford the opportunity in the vehicle that Tara is talking about, the idea that there has to be a new way of doing this. It's not unique to Ebola. It certainly would not be unique to some kind of other epidemic, potential disease, but quite frankly, it's kind of common in any diseases that we have in our society, that we have kind of a hit or miss approach to develop countermeasures, whether it be for heart disease or cancer. In some ways, having a more rationalized approach broadly would benefit across disciplines and not only improve health potentially, but also lower the costs of health. And that's another part of the equation here. But, there are opportunities, and to quote Rahm Emanuel, which I don't often do, is to cite the idea that, you don't don't let a crisis go to waste. In this case, is rather than trying to address the Ebola problem, see if you can address a larger set of issues through the Ebola problem to identify the things that will make a difference, not only for the next epidemic, but for the next common thing that also has a way of causing us both significant disruption and cost.
Yeah, I would just add quickly to that I'm not sure I'd put it as starkly as Tara did, that programs to generate countermeasures have mostly failed. But I would say that those programs can be improved. We need to do better at research, and we need to do better at generating new research for the challenges that we face, as opposed to finding ways for biopharma companies to leverage their existing products into something that the stockpile might want to have.
Right. Yes, the young lady right there. This one, and then, no. Okay, we'll get you next. All right,
Whoever has the mic should go.
yes.
Pyle Zaveri, Talk Radio News. You guys touched on this a little bit, but I was wondering if you could give your perspective on the quarantine policies that have been put in place by a few states.
I'll take a whack at that. Being a New Yorker, I believe that the governor of New York and the governor of New Jersey are doing what they think is in the best interest of their people. I think it highlights, if you will, a little bit of a chink in the armor of the guidelines that CDC put out. This is not to be construed as a criticism, but as a medical epidemiologist, I'll just kind of cite, if you will, the facts. Besides potentially eating bushmeat or being exposed to fruit bats in Africa, subject to the risk of contracting Ebola, probably the greatest risk factor for anything or anybody is being a healthcare worker taking care of someone who has Ebola. The issue in the current CDC guidelines leaves open for interpretation the role of controlled movement or unfettered movement, they have the word for that could be used for a variety of different people, and they don't necessarily highlight healthcare workers who have been exposed to Ebola to be at higher risk. Now, obviously, in the Dallas case, it was the only risk for those two nurses. But I think in the case of, if you look at the natural epidemiology in Africa, you can argue that healthcare workers taking care of Ebola victims have a greater risk, and it's dependent on their ability to effectively manage and protect themselves through personal protective equipment. In Africa today, that's a well-exercised effort by the number of volunteers and healthcare workers who are doing heroic things. The question is that the same in the United States? Again, you can argue, at least in the case of Dallas, for people not familiar with this activity, not familiar with managing Ebola cases, not familiar necessarily with the personal protective equipment, that may be an issue. Now, you can look what's happening in New Jersey right now with the nurse today who's effectively in quarantine. You could say maybe that was a little bit too stark of an approach. Maybe the right choice would have been a staycation, if you will, in terms of ensuring that person remained at home, had assistance available to do so, and be able to monitor that. But I think it just represents sometimes the challenges of trying to put together guidelines that are universal in their reach. Again, CDC just makes recommendations. It's really a state and local responsibility to implement them, and state laws determine that. and that's, again, a reserved function identified in the Constitution, that they have the right to do that. How that gets implemented, or if it gets implemented appropriately, obviously they'll be sorted out here soon enough, but it just highlights, I think, some of the challenges that are out there.
Well, I think there's a reason this is a challenging issue, is because there are some important principles that are in conflict on this. There's obviously the constitutional right to free movement, and you can't be incarcerated by your own government without just cause. At the same time, there's the right of the public to safety, and you want to encourage people to feel safe going about their daily lives. So there appear to be some conflicts here. One thing that I was thinking about was perhaps Doctors Without Borders, I think, has a smart policy of telling doctors who go to serve in these areas that they should not return to their hospitals for 21 days after they return, and agreeing to that in advance. And then perhaps public health care workers who go there should agree to not only aggressive self-monitoring, but self-quarantine before they go. Now, one other issue here, and this is what Dr. Fauci talks about when he goes on all of the Sunday shows, is this question of will it encourage or discourage, or more likely, will it discourage healthcare workers from volunteering to address the real problem in the larger problem in Africa, in West Africa, and will it discourage healthcare workers from going to compassionately serve and try and control the spread of the virus there. And obviously we don't want to discourage people from going there. I'd love to hear Charlotte's views on this particular aspect of the question.
Yeah, I think that Dr. Fauci's comments on discouraging people, even with what USAID and the DoD are going to be doing in the affected countries, they're building facilities. There's no one that's going to be staffing those facilities. It's going to be reliant upon local public health officials or those volunteers willing to put themselves in harm's way. And so I think we're about to have 17 new facilities online by next year, and they're going to need doctors to fill those facilities to treat victims. So I think that's another side of it. And kind of looking at what other governments have done in the region, I think Senegal and Nigeria both declared Ebola-free last week from their particular cases. They're still not out of the woods yet. I think they're in the neighborhood that travelers and other people will likely come back. But and looking at the quarantining policy that the Nigerians put in place, kind of layered upon an already existing polio outbreak protocol. But it was, if you had been, directly exposed to an individual, then you were put in a particular facility. And this is because Nigerians don't have enough officials to actually go visit constantly during the day. I know that New York has altered their system, but I think that there are lessons to be learned from some of these countries that have, successfully contained an outbreak. That the original Liberian diplomat in Nigeria had contact with 900 individuals, or through the tracing system. So, kind of looking at the successes of that model and seeing that it does work. You have to act quickly, you have to act efficiently, but we have, been successful.
I think that point deserves emphasis. Imposing quarantine in 24 hours is irresponsible. It's a big deal to do this. And it's not going to be one nurse or one doctor. I mean, we're going to have cases come into the United States through all kinds of airports. And you have to be able to explain why you're quarantining somebody who has no symptoms of Ebola. Because there's no scientific evidence that that person actually represents a public safety threat. And you have to make sure that person can get something more than, a granola bar that the nurse had over 12 hours. Which of us could actually stay in our home for 21 days without some kind of outside support? I would run out of cornflakes in about 3 days. So if you're going to quarantine people for a good reason, you have to be able to explain that reason, because again, the confidence of the public is your key tool in controlling disease. And you have to be able to actually effectively implement it. And that is really hard in modern societies. It is really challenging. And I think doing it cavalierly kind of blows both points. makes you seem uninformed as a leader, and it also diminishes the public's capacity and confidence in your effectiveness. So I think this was a mistake. We'll recover from it, we'll amend it. And again, you always learn in epidemics.
Okay, the young lady right there.
Hi, Jackie Fulgham, Middle East Institute. There have been numerous calls for travel ban of those who have traveled to high-risk Ebola countries. What do you think of the effectiveness of this proposal?
Look, when we were in the Bush administration, we looked at this question of travel ban, and the way you need to look at it is there's pros and cons, and you only would want to do something this significant when the advantages outweigh the costs. And you have to think about what those costs are. And the costs are discouraging travel for healthcare workers, making it harder to get resources there. You also have the issue of you don't know how governments will react to the U.S. or any other country shutting off travel from that nation. So, for example, when we were dealing with flu situations, one thing we were very worried about was maintaining the cooperation of the Indonesian government, which didn't always want to share flu samples with the U.S. So you might think that Liberia, Guinea, these are tiny countries, what can they do to the U.S.? But you can't necessarily predict how another state actor will react. I mean, you can't always assume that there's going to be what we consider to be rational responses, and so countries can react very strongly to this, which is really an assault on their ability to maintain a viable economic system. So I am loath to impose a complete travel ban. I also think that I'm not sure a travel ban, depending on how you configure it, but if you say Liberians, for example, can't come to the U.S., that wouldn't necessarily have stopped the situation of Dr. Spencer, who's a U.S. citizen with a U.S. passport, and he could come into the country. So you have to think very carefully about how you do it, and I'm reluctant to just do a blanket travel ban at this point in the situation.
I do think that there are kind of some lessons to be learned again from Senegal and Nigeria. Senegal, shares a 330-kilometer border with Liberia, so their position, I think, is a bit different than Nigeria. They did not implement any travel bans. They did within, I think, it was a near 48-hour period where they were limiting local carriers because they had not put in monitoring checkpoints, but after that point, they did reopen all links. On the other side of that, Senegal, that does share a direct border with an affected country, did close down all of their border checkpoints. Even shipping coming into the country via sea lanes was also canceled until the Ebola, until they were declared Ebola-free. I think those have been reopened at this point. But I think kind of seeing that in Nigeria is, it is much more economically connected and a part of this hub, but it is a couple steps removed from the affected countries, and so kind of thinking along those lines. And some of the other countries, Ethiopia is another one that has a lot of travel links to the region. They've put in some pretty strict temperature measures when you enter the country from one of those places, but again, they've kept links open. And even looking at the considerations of the travel ban, there are no direct, I think most people know this at this point now, there are no direct flights from the region to the United States. So it kind of, then that starts getting into, well, what do we do with our European friends, or what do we do with our Middle Eastern friends? Because Emirates flies several flights into the region. So I think it mushrooms out a lot faster than I think people initially realize when it sounds like a quick fix.
Okay, I'm going to exercise my moderator's prerogative here. I'm going to ask the last question. Same question for all four of you. You have about a minute apiece to answer. You have been named the Ebola czar. And I have to tell you, there are a couple of people standing up in front of you here that would have been really good candidates for the Ebola czar, based on their experience and knowledge. What is the one thing that you would put into place today? Whoever's ready can go first. Nobody's ready.
Ladies first.
All right.
I'd establish an assured air bridge for medical workers who get sick in Africa to advance medical care.
Okay.
So the first thing I would do would be attempt to refuse, but it's like William F. Buckley when he was asked in 1965 if he had won his kind of a quixotic attempt to win the New York mayoral election. He said the first thing he would do would be demand a recount. But obviously, I think the number one thing you have to do is, from the perspective of that position, is to get a better handle on the U.S. logistical capabilities and better cooperation within the very siloed pieces of the U.S. government and make sure that they are working in concert and not at loggerheads.
I think that, leveraging private sector both in the U.S. and in the region, there have been some efforts. I know there's a UN committee working to do that, but I think that there's plenty of private sector organizations in plenty of these countries, American or, Liberian, Sierra Leonean owned, that actually have a lot of resources and have the ability to actually change what's going on the ground.
So I'm going to cheat a little bit because I think there are three things that have to be done, so I'm going to not stay with one. But first of all, I think it's been highlighted the logistics piece of this and how do you effectively project the power of the United States to do what it can across the region. The second thing is I particularly believe that there's got to be a means to basically fill those Ebola treatment facilities, and we need to think creatively about that. We've really been relying on faith-based organizations, non-governmental organizations, and I just highlight what the Germans did, where they offered the German military healthcare workers basically to go on paid leave that wouldn't accrue on their personal leave to basically go and help respond to the Ebola outbreak. So there are entities in the United States that probably could do something similar around that. And the third thing is that the one thing the United States has that we can pull on this is really to provide and to accelerate finding safe and effective countermeasures, which we have, certainly early in development in that way, but could be deployed fairly quickly if they go through the kind of necessary, if you will, clinical trials domestically before we apply them internationally. So that would be my short list.
Okay. All right. Well, folks, I don't know about you, but this has been one of the most reasonable, fact-based bodies I've seen discuss this, whether it was on TV, on the radio, or in print. It's a treat to talk with professionals about things that their knowledge informs rather than just on emotions. And I'd ask you to join me in thanking the panel. And I want to thank all of you and the folks that are here either online or on TV for joining us this morning. Thank you very much.